All right, Sandy, you're up.
Can do. All right, everybody. I have the good fortune and the pleasure of introducing all of you today to Dr. Richard Tyler. He is the Director of Audiology in the Department of Otolaryngology at the University of Iowa. Dr. Tyler is trained as a clinical audiologist and psychoacoustician and is now the Director of Audiology in the Department of Audiology, as I said, the University of Iowa. He sees tinnitus patients weekly and hosts an annual Tinnitus and Hyperacusis Treatment Conference. He has served on committees for the National Institutes of Health, the National Science Foundation, the World Health Organization, the Department of Defense, American Academy of Otolaryngology, and the Veterans Administration. He's also been a visiting professor in Australia, South Africa, France, and China. So we're very happy to have you with us today. We're very fortunate to have you with us today. We appreciate your time and your willingness to provide the class for us. So I'll go ahead and turn it over to you and we'll get started.
Dr. Tyler also has worked with the IHS Institute for International Institute for Hearing Instrument Studies to develop the Tinnitus Provider Certificate Program that is offered through IHS. As a previous class participant of his, I highly recommend it. It's worth every single penny, and I encourage anyone that has any interest in tinnitus to take the class.
Okay, so I'm glad that you're all interested in tinnitus. This is a great thing. Let me start off just asking you, does anybody know why this person is screaming? You're all wrong, sorry. Okay, we're going to talk a little bit about measuring tinnitus and go into the overview of tinnitus activities treatment that includes thoughts and emotions, hearing, sleep, and concentration, and finish off with some strategies for hearing aids and sound therapy for our tinnitus patients. So first of all, measuring tinnitus and the reactions. So we called this our psychological model, and that is that the tinnitus has some characteristics to it, pitch and loudness and so on. And we're all different. We all have different psychological backgrounds and experiences and challenges in life. And the annoyance that any individual faces with their tinnitus depends on not just how loud the tinnitus is and what it sounds like, but also their individual psychological makeup. So important to keep that in mind for all of us. So for pitch, doesn't sound like a pure tone usually, but sometimes does, but we're looking for the most prominent pitch. And there are several different methods. I don't always measure tinnitus in the clinic, but just some general points is that generally keep it simple. For pitch matching, you're always going to use monaural stimuli. Specifically, you can test in the ipsilateral or the contralateral ear. And pitch matching for most patients can actually be quite variable. For loudness, you can do a loudness balance, but an easiest thing to do is loudness magnitude estimation. Rate the loudness of your tinnitus on a scale from 0 to 100, where 0 is very faint and 100 is very loud. We can also have the patient adjust the presentation of a pulse tone so it has the same loudness as their tinnitus. And there's several different ways of doing that. You just have to specify which way you're doing it if you do choose to measure it. Sometimes it's helpful. I also was interested in masking tinnitus, and this is examples of some audiograms. You can look up in the upper right-hand corner first. This is the pitch match frequency. And for some patients, it took a high levels of sound pressure level, of signal levels, independent of the masker frequency. For other patients, just 5 or 10 dB above threshold, independent of the masker frequency, you could mask the tinnitus. For other patients, you simply could not mask their tinnitus. So they're all different. Part of the motivation here is to try and sort out these differences. Interestingly, for some patients, you could mask the tinnitus best with pure tones that were close to the pitch match frequency. And that actually suggests that, at least in these patients, maybe the tinnitus starts and originates on the basilar membrane in the cochlea. So that was an attempt to look at some of the causes. We also looked at post-masking effects. This is now called residual inhibition, but it's not known what the mechanisms are, and it's not always an inhibition. So we have patients listen to their tinnitus, we turn on a masker, we turn it off, and some patients hear their tinnitus right away. For other patients, their tinnitus is reduced in intensity, and then gradually it comes back. For some patients, the tinnitus is completely gone and then gradually comes back. For other patients, the tinnitus is gone completely. And I recall when I first started doing this work, when I worked in England, some 35-year-old man came out of the soundproof booth crying. He was crying and he said, "This is the first time in 5 years I have not heard my tinnitus." And I'll never forget that. For other patients, you turn the masker off and the tinnitus gets worse. And usually, almost always, it comes back, but it's something to be concerned about here as well. So, how to measure the reactions to the tinnitus? Well, clinically, we developed this open-ended questionnaire. Please list the difficulties you have as a result of your tinnitus. And we can do that for the patient waiting in the waiting room, or we can send it to them electronically before they come into the clinic. But it gives them opportunities to list what's important for them. And it's sometimes a good place to start with the counseling. We've also developed a tinnitus primary functions questionnaire, and these are some examples. I have difficulty focusing my attention on some important tasks because of my tinnitus. My emotional peace is one of the worst effects of my tinnitus. In addition to my hearing loss, my tinnitus interferes with my understanding speech, and I lie awake at night because of my tinnitus. So we've used that tinnitus primary function questionnaire in some studies to document the efficacy of tinnitus activities treatment. So I'm going to give you an overview of this tinnitus activities treatment next. And the 4 different areas affected by these tinnitus patients are thoughts and emotions, hearing, sleep, and concentration. Not everybody is affected by concentration. Not everybody has sleep problems, but most of the patients we see have problems with their emotions, and that's why they come to see us. And almost all of them have difficulty hearing. It's sometimes difficult to sort out what hearing problem is caused by the tinnitus and what hearing problem is caused by the hearing loss. But at some level, that doesn't matter. We still want to help them with their hearing. So typically we have an introductory session, but then I'm going to say 1 topic per counseling session. And usually these last about an hour with about 2 weeks in between. And I'm obviously not going to go through everything in any detail, but I want to give you a broad perspective of the different things that are available, and you can take your time depending upon the individual needs of that patient that you're seeing. After the session, they go home with homework. They practice it in the clinic before they go, and then they go back and do their homework, and they come back depending upon how far away they live, a week later, a month later. And when they come back after that week or 2 weeks, we go over their homework as the first step, and then we go on to the next topic, for example, hearing, after they've been through the thoughts and emotions. So that's the general strategy for doing this. So as an introduction for these patients, where do you want to start? So instead of thinking that I know everything and I'm going to help this person, I want to know where they're at. So I take my time and I listen to them. I let them tell me what's happening in their life. For example, what do you think caused your tinnitus? When your tinnitus began, what was your life like? What was happening to you? Anything special? How has tinnitus influenced your life? So again, I want to be a good listener here. I want to see what their perspective is. And how do you think we might be able to help you? I don't have any magic pill either, so I want to know where the patient is at and why they're here to see me. And sometimes they come up with a long list of medications they've tried and people they've been to, but I want to know, basically in a nice way, why they've come to see me and what their expectations are of seeing me as well. So that's a good place to start. And then how would you describe yourself right now? Are you curious about this? Are you concerned? Are you distressed? What are some of the things that you're doing? I want to understand where the patient is at. So I take some time and be a good listener. So then we're going to decide with the patient based on the questionnaire, usually, and some discussion with the patient, what different types of things that we're going to pursue with that individual patient. Thoughts and emotions, hearing and communication, sleep, or concentration. So this is the first session, thoughts and emotion. And again, I'm going to go through these pretty quickly, but I just want to give you an overview of the different things that are available and how we might be able to help the patient. So thoughts and emotions, we go through hearing loss, and tinnitus. We talk about attention, behavior, and emotions, and how tinnitus might actually change you and how these reactions can be changed and how we can help you change your reactions. So we talk about the importance of hearing and communication, and how tinnitus can actually affect your hearing and how you can improve your hearing. We talk about sleep, how there's quite a wide variety of normal sleep patterns, and tinnitus can affect sleep. We're going to go over some activities to facilitate sleep and what to do if you wake up at night. And then concentration. So things can affect our concentration, including tinnitus, and what can you do and how can we be helpful to help with that. So we're going to include sessions only relevant to you. So if you don't have any problems sleeping, we'll avoid those. We're going to give you some materials to go over. We're going to answer all your questions. We're going to practice these activities here in the clinic, and then you're going to go home with some homework. So here's the thoughts and emotions session, some examples at least anyways. So we're going to talk about hearing and hearing loss, tinnitus, attention and behavior, changing your reactions, and then some activities you can do at home. So we'll talk about hearing and hearing loss. So we go through with them when we talk about the different parts of the ear and the middle ear and the inner ear and the hearing nerve going up to the brain. The hearing nerve going up to the brain is important for these patients because we're going to talk about this activity on the nerve. And I sometimes tell the patient it's like a flashlight going on and off. It's a little spike of electrical activity that sends the information up to the brain. And it turns out that, you have 20 or 30,000 nerve fibers in normal hearing, and those nerve fibers are actually active spontaneously even when there's no sound. And your brain monitors all that, but for low-level spontaneous activity, your brain has learned to ignore that. So no sound, you hit silence. When there's a word presented, like the word table, then there's different kinds of activity on all those nerve fibers, and your brain interprets that as the word table. If it's a cricket, there's lots of activity going on in the nerves over time, and your brain recognizes all that activity as a cricket. So we'll come back to that. Lots of different causes to tinnitus and hearing loss. Head injury, medications, noise, the aging process. Here's that normal activity on all these nerve fibers, lots of information going up to the brain. When you have a hearing loss, you lose some of those nerves, and on some of the nerve fibers, the activity is reduced. Unfortunately, there's no cure at this point for hearing loss. We cannot replace hair cells. Hearing aids, however, can be very helpful. They can make sounds louder, easier to understand. They don't restore your hearing to normal, but they can provide very, very importance. So now we're going to look at your audiogram. So we get their audiogram out and we go through that with them. So you tell me about your hearing now. How is your hearing experience? And what do you think caused it? And what have you done to improve your hearing ability? Then we're going to go through their tinnitus. So what's it sound like for you? It's heard differently by different people, ringing and buzzing. It turns out that tinnitus results from hearing damage, usually, often, almost always associated with some kind of hearing damage. The tinnitus itself will not damage your hearing. And it's likely, because we're all getting older, that your hearing will continue to decrease. But usually the tinnitus itself does not get worse over time, in most cases. Many different causes of tinnitus, just like hearing loss. So noise exposure, the aging process. What was your cause? And again, I want to be a good listener here as well. So you'd be surprised, but tinnitus is very common. You probably know people, you probably have friends that have tinnitus, but because it's invisible, you don't know it. You don't know it, but you probably have friends that have tinnitus just like you. As there's no drug or surgery, but there are some things that you can do to change your reactions to the tinnitus and how it affects you. And we're here to help you. We go through a little bit of the auditory system and the brain, the auditory cortex and the different parts of the brain that controls the reactions to our experiences of sound and distress. So I go back to the activity on the nerve fibers. You hear silence, you have a hearing loss, you lose some of those nerve fibers. For tinnitus, there is some activity going on, some hyperactivity going on some of these nerve fibers in your auditory system, and your brain is doing what it's supposed to do. Your brain is doing what it's supposed to do. It's interpreting that sound, that activity, as a sound. This is very helpful for some of the patients. They're not making things up. They're not mentally ill. They have some hyperactivity on some nerve fibers somewhere in their auditory system, and their brain is doing what it's supposed to do. It's interpreting that activity as a sound. So this is an important point to make with the patients. So what does your tinnitus sound like? So whistle, cricket, what does it sound like? It's going to have some different activity on nerve fibers depending upon the sound. Okay, different ways of paying attention. Lots of things capture our attention, and our emotional state has an effect on how we capture attention. So lots of things we can look at and experience, vision and taste and smell and sounds. And we can usually focus on one thing and ignore the other things that's often in the background subconsciously, but we can usually focus something on smells or sounds or even something we feel. But if something in the background, like a police car drives by, that grabs our attention and the other things go into the background. So things that grab our attention are unusual things, important things, scary, unexpected things. We can pay attention. If we realize that the police car is driving by, we can learn to ignore that. And we can do something also. But if we're uncertain about it, we're not quite sure what's going on. If the police car stops in front of our house, then it won't be so easy to ignore. Tinnitus does not make you deaf. It doesn't lead to senility. It's not a sign of mental illness. When you worry about such things, you can be preoccupied with your tinnitus. So for activities here, we want you to describe an image that you like a new car, and an image you don't like. Describe a sound that you like and one you don't like. And describe your tinnitus. What does your tinnitus sound like? So how can you change your reactions to your tinnitus? Well, it's important that our thoughts have an impact on how we react to different things. So we can have neutral thoughts, oh, it's just a sound. Could have negative thoughts, oh, what's going on? I'm afraid of that. Or we can have positive thoughts to some sounds. So for example, the doorbell rings. Okay, it's just a doorbell. 2 weeks go by and the doorbell rings and there's a fire outside of our house. The next day, the doorbell rings and there's been a car accident outside of our house. The next day, the doorbell rings and our tree has fallen on the neighbor's lot. 2 weeks go by and the doorbell rings and someone has sent us flowers. The next day, the doorbell rings and a friend has arrived. The next day, the doorbell rings and someone has sent us a present. It's all the same sound. It's a doorbell. But our experiences and our anticipations of that sound changes how we react to it. So, what kind of thoughts have you had about your tinnitus? What situations do you experience where your tinnitus is bothersome? What do you think about your tinnitus? How do you feel about it? So how can you change? How can we help you change your reactions? Well, if you think about the importance of it, you can change your emotional reactions, perhaps refocus on other activities, maybe reduce the contrast between the tinnitus and some background sound. So, as we said, tinnitus is likely the result of some increased spontaneous activity someplace in your auditory system. Many people have tinnitus. You're not alone. It's not life-threatening or dangerous. It's just an activity going on in some of your nerve fibers. So it's your reaction and your tinnitus are actually two different things. So if you're thinking about it, you have a negative reaction, you're going to have negative thoughts. Anxiety about it, you're worried about it. But if you're less bothered by it with some constructive thoughts, eventually the tinnitus might not be as prominent the way you think about it, and you won't have that constant reaction to it. You can change your emotional reactions. So what can we all do to help us think about refocusing our thoughts and emotions? Well, we can do other activities. We can keep ourselves busy. So what other hobbies do you have? Have you explored any of these activities to help you ignore your tinnitus? What about trying some new activities? What about getting involved in a new club or a new activity that might help you put that tinnitus in the background? Okay, we can also reduce the contrast between the tinnitus and the background sound. And we go back again to our example of this hyperactivity on your nerve fibers. If we play a low-level noise, that low-level noise can, for some situations, can actually camouflage or make the tinnitus not stand out the same way that it did before. An example here is if you see a candle in a dark room, it stands out. But if you open up a window behind the candle, then the candle, and the analogy is the tinnitus, isn't standing out in the same way. It's a dog barking. You don't like dogs, it's not your dog. You turn on a fan and you keep yourself busy doing something else. And eventually, over time, that fan and the dog barking sort of drifts away, fades into the background. So lots of ways to add different low-level background sound. And there's relaxation CDs, smartphone apps, nature sounds, music. We're all different, but lots of different things that you can use. Here's some examples that many people have used: rain and waterfalls, just static noise in general. Okay, part 5 is the action plan for this. So we'd like you to practice focusing your attention on tinnitus and then focus on something else. We want you to identify some activities that you enjoy, that you can explore and keep your mind occupied. And also, please try some different low-level background sounds and see what helps you make your tinnitus less prominent. So that's the strategy. So they also go home every session with a little diary, and this is part of what their homework is. So for example, we want them to write down their thoughts and worries about tinnitus. We don't want them to do this all the time. This is just the first thing. And then check and see if these thoughts match what's happened. And so, and why don't you write down some alternative ways about how you can put tinnitus in the background. And when you come back next month or next week, we're going to discuss this, what's happened for this diary. So try and keep track of some things that reduce your tinnitus or that make it worse, but just write down some activities that you enjoy and some sounds that you enjoy. And try some of these activities and see what helps you make your tinnitus less bothersome. Or what sounds that you tried to see if that helps you with your tinnitus, making it less prominent. So this is an example of the diary they go home with. So we want them to practice some of these things, and we practice some of these things in the clinic before they go home. Walking and their birds chirping in the park and things like that, and their tinnitus was not as noticeable. Okay, hearing and communication session. This is the second session then. We're going to talk about the treatments, hearing and communication, how tinnitus can affect hearing, and activities and so on. So some of this actually has to do with the same sorts of things that you might do for anybody with a hearing loss. So I'll just skip through some of these. Reducing communication difficulties. So what kind of difficulties do you have? And how do you think your tinnitus affects your communication problems? Well, we have them bring out their audiogram, normal pure tone thresholds. What does your hearing threshold look like? And we might talk about the causes and go through that already probably. What factors affect communication in general? Well, not just your hearing, but also the background noise, the ability to see the speaker's face, how familiar you are with the talker, how familiar you are with the topic, and if you're under stress or not. These are all things that you're probably already clearly aware of, but the patient may not be. So we go through about hearing loss, we go through how the audiogram can affect the perception of different sounds, the E's and the ahs and the vowels. We talk about background noise and how one strategy is going to be to remove yourself from background noise if possible, reposition yourself, and the importance of being able to see the speaker, not just the lip reading, but also facial cues and body language, and we practice some of these. So what situations do they have? We want to hear them. So we're not just lecturing them, we're listening to them during these counseling sessions as well. We want to know what techniques they've used that's been successful or unsuccessful. And we're going to talk also about tinnitus and affecting hearing. So tinnitus is not specifically damaging your hearing system. It certainly can make sounds harder to hear, and it can also mask some sounds. So again, different in different people. So you can improve your hearing with hearing aids and reducing background sounds, watching faces, repair strategies. We're going to go over some of these in the clinic before they go home, and using effective communication. So of course, hearing aids are very beneficial, and we're going to go through those, including just speech perception, but also localizing sounds and figure out how things are going on. Watching faces, including good lighting, repositioning if necessary, and asking the talker to slow down. Excuse me, I have a bit of a hearing loss. Do you mind slowing down a bit? And I want to make sure I can see your face. Make sure they're focused on you. So we're going to do some activities in the clinic before they go home for their monthly session. We want to show them the difference between being able to see our face and when they cannot see our face. We can change the lighting, we can move around, and have them rehearse some of the repair strategies before they leave. Okay, the next session is on sleep. And again, I'm just going through some of these to give you an idea. All of these tinnitus activities slides in their fullest are available on our University of Iowa website to download for free, but you'll also get the slides that I'm going to share as well. Rick's going to give you these at the end of the presentation. So for the sleep session, we're going to talk about normal sleep activities, things that affect sleep, daytime activities, evening activities, preparing for sleep, what happens if you wake up at night, wake up early in the morning, and we'll give you some activities to go home. So normal sleep varies quite a bit from patient to patient, 6.5 to 9 hours. Often I wake up sometimes 3 times a night. And tinnitus doesn't usually wake up patients in my experience. But it's reasonable that if you're under stress, then if there's some background noise or light, if your work schedule is changing, jet lag. So these are all reasonable things that affect all of our sleep. Physical condition we're in, we're on some medications, caffeine, nicotine, alcohol, all these things can affect our sleep. So daytime activities, don't take any naps, get regular exercise, but not within 3 to 4 hours of sleep, and try and keep going even if you're tired. Usually it's good to have a regular cycle, and after a certain time, an hour or two before bed, don't get into exercise or eating or too much alcohol. So preparing for sleep, low-level background sound. A lot of patients already use a fan or a humidifier, lots of smartphone apps, sound generators beside your bed. There's even a sound pillow app now that can go inside your pillow and control the sound that you hear in your bedroom. So choose something that's soft and easy to enjoy, calm, soothing, and for example, wave sounds or broadband noise. And again, we'll play some of these sounds for the patient in the clinic before they go home. And here's an example of the sound pillow here that might be helpful for some of the patients. So we actually go through some sleep and relaxation exercises in the clinic. Everybody's different. We all have different likes and things that are good for us. There's progressive muscle relaxation, visual imagery. Here's some things where you can have the patient lie down or sit up, but feel comfortable. Practice tensing your wrist. For example, we would say, close your eyes, close your right fist and squeeze it really hard and think about that tensed muscle. Think about that tensed muscle. Now slowly relax the muscle. Keep your eyes closed and slowly relax the muscle. So that's just an example. Obviously, these things can take several minutes, several hours for some patients. Good for all of us. Starting with arms, here's the example of the fist. Breathing deeply and feeling your arm. I also, we used this before people started talking about mindfulness and meditation. I like the one visual imagery. Close your eyes, thinking about being on that beach in Jamaica. You can hear the waves, smell the water. And actually, I had a cataract removal 2 days ago without any anesthetic. And I could experience everything they were doing during the cataract removal. But what I used is this visual imagery. I could feel that I was in the operating room laying down, keeping still, but I used visual imagery, thinking about the palm trees, thinking about the waves, and keeping myself calm as I was experiencing this cataract removal. So you can share experiences like that with your patients. And again, these things are good for all of us. And you can practice some of these things in the clinic before they go home. So the activities they'll have before they go home include practicing for their sleep and daytime and evening activities, prepare for sleep using some of these relaxation techniques. So the fourth and last session has to do with concentration. So things that affect concentration, we go over with that in the clinic again before they go home with homework. Things can distract all of us, background noise, temperature, lighting. What problems do you have with concentration? And again, not everybody has problems with concentration, so we only use this module if the patient says they have difficulty concentrating. So tinnitus can affect your concentration. If we're focused on the tinnitus, then it's harder to concentrate on other things. And we have these different strategies of avoiding distractions and adjusting our work habits. How can you decrease the prominence? And that might include sound therapy, we'll talk about in a minute. If you're thinking about your tinnitus, the more you think about your tinnitus, the more you're going to think about your tinnitus. So we want you to it's just a sound. It's not a good sound or a bad sound. So it's in the background. Can you think about something else? Can you concentrate on some other activity and ignore your tinnitus? It's just a sound. It's in the background. So we can practice again in the clinic before they go home, staying focused on a particular activity. Using background sound can be helpful, again, in the clinic. And then have them taking control. So part of this actually is, focus. You can, again, close your eyes, or you can use their eyes. You can to focus on a chair or focus on a computer. Close your eyes and focus on sound. So switch attention from one to the other. So we're going to practice some of these things in the clinic before they go home, being in control of their attention so they're not feeling overwhelmed. They're in control of this. And so that we use visual attention examples. Sorry, I thought I turned that off. And then sound examples. So we can listen to different sounds in different rooms and again, practice this before they go home. So pay attention to sound in the room, and now pay attention to your tinnitus. So we also have patients pay attention to their tinnitus. And that sounds a bit weird, but again, we're just giving them control here, giving them some control. So the activities they're going to do when they go home for these attention control activities is visual, sound activities, sound plus tinnitus, and sound plus reading. Okay, so that's just a very quick overview of the tinnitus activities treatment, showing the 4 different areas. Again, depending upon the individual, we don't have to do all 4 of those. We do want to focus on only the activities that person has. Almost all of them have problems with their emotions. They almost all have problems with hearing, and many of them have problems with sleep, and some have problems with concentration. Okay, hearing aids. Well, this is a survey we did a long time ago, and this is interesting because this population with tinnitus, 44% said they had normal hearing, but they didn't. It was just they had a mild hearing loss, or their hearing loss came on gradually, and the tinnitus was the biggest problem for them. These people over here knew they had tinnitus and knew they had hearing loss, but they didn't have hearing aids yet. So this is a great opportunity. Tinnitus is a great opportunity to connect with people who can also benefit from hearing aids. So for a lot of people who get hearing aids, in this study of over 1,000 people, half of them say the hearing aids didn't have any effect at all. About 4% said the tinnitus was made worse by their hearing aids, so that might mean turn down the maximum output. But for almost half of the patients, they said actually the tinnitus helped by the hearing aid. So that's pretty positive as well. So hearing aids can help because they're improving our communication and amplifying some background sound. Sound therapy, I think you all know, can also help many patients. Jack Vernon took me to this little park in Portland, where a patient took Jack to this park and told Jack, this is the only place where I don't notice my tinnitus. And Jack then connected with the company and developed the first sound therapy devices based on these waterfall broadband noise. Many different neurophysiological models. So tinnitus likely has, as I said, some activity on some nerve fibers. You present some random noise, and when you present both of that at the same time, that can eliminate that ringing sound. Lots of different strategies. Jack Vernon suggested total masking, where the person hears the masker instead of their tinnitus. That works for some. I was a little worried about how intense that was, and it might make their tinnitus worse or their hearing loss worse, so I suggested partial masking. So this is an example we use for the patient to explain total masking, and this is how we explain partial masking. So partial masking, where they can still hear their tinnitus, but it can actually reduce the loudness and reduce the prominence of their tinnitus. Jastreboff later came on and introduced the mixing point, where the patient can hear the tinnitus, but the background sound is just below that. So this is what he suggested, that as you increase the noise intensity, at the mixing point was the best. And when you covered up the tinnitus completely, you were not able to be effective. And I've shown that to be not true. The mixing point is too loud for most patients. The mixing point should not be the goal. You should be using the lowest level that is effective for that individual patient, and they're all different. Okay, so there are lots of different sound therapy options, as I'm sure you're all aware, including different broadband sounds. You can modify the spectrum, modulate the envelope. The hearing aid companies have really got on board with this in the last 10 years, or 5 years in particular. They're combining tones and modulated tones and different music strategies. They can adjust the background sound depending upon the individual's audiogram. And there are some strategies for notching noise and notching music around the pitch match frequency. So no one of these is better than any other, in my opinion, but it's good to have some choices so the patient can experience some of these different sounds. You have to be careful with some of the patients because the background sound can actually make the tinnitus worse in some subjects. And also, if they have hyperacusis, we would strongly recommend that you treat the hyperacusis first, and that's a different presentation with our hyperacusis factories. But background sound can help most of these patients. So I just want to mention about referrals. So when you're seeing these tinnitus patients, obviously if there's some deformity that you can see, if they have drainage in the ear, rapid hearing loss within the last 90 days, if they're dizzy, if they have unilateral hearing loss in the last 90 days, an air-bone gap, if you can see cerumen coming out of their ear canals, or if they have some pain or discomfort that's not related to the sound hyperacusis. So seeing these tinnitus patients, you have the great opportunity to be a lot more helpful for these patients. You'll see a lot more patients and a lot will benefit. So in conclusion, there's a wide variety of sound therapies available now. This is a wonderful thing. You can combine the sound therapies with a counseling strategy, for example, tinnitus activities treatment. Low-level partial masking is best for most of these patients, and a wide variety of options are useful to let the patient choose what works best for them. So as I mentioned, we have an annual tinnitus conference every year as well in Iowa City. Our next one, we've modified the date here, but this is our tinnitus conference in Iowa City. It's August 12th and 13th. And I'll finish off by just saying, I often go to a coffee shop and somebody has done a watercolor of the screen as I'm sitting at this coffee shop, and I'm thinking, wow, that's fantastic. Imagine that, a watercolor on this glass window. And then I look down, and this is why he's screaming. He has dropped his coffee. So now I figured it out. So, okay, so that's the end. So Rick, did you want to take over?
Yeah, sure. Thank you very much. Very valuable information. And again, like I say, I encourage everyone who is interested in learning a lot more about tinnitus. This was just kind of a brief overview of Dr. Tyler's hearing tinnitus provider course offered through IHS. And that's given about once a year, sometimes twice. So keep your eye open for IHS literature on that. It's very valuable. A couple of questions we want to go through. First of all, are there any questions for Dr. Tyler before we go through the assessments? Yes?
Yeah. What, in your experience, is the prevalence of musical tinnitus?
So a musical tinnitus is where somebody actually hears music, some kind of music sounds. Yeah, so that is very rare, but it was first identified quite clearly in Montreal by a brain surgeon. And it looks like that what the explanation was that there is some hyperactivity starting in the brain in an area that normally would be responding to music. And so he actually focused on some other brain patients he was working with that didn't have tinnitus at all, and stimulated by putting electrodes in the temporal lobe and stimulating different areas of the brain with electricity to activate them. And in some areas, the person heard music. So again, it doesn't happen very often, very, very rare, but every now and again, you know, some patients will hear music and some patients will even hear voices. And of course, you need to make the distinction between somebody who has a mental illness and hearing voices, but there are some people who do not have a mental illness. There is just some hyperactivity going on in their temporal lobe, and they hear music or sometimes words. And it's not a mental illness. There's just some hyperactivity going on. Doesn't happen very often at all, but it can happen.
Had one patient in 44 years that struggled with this. And what a nightmare it was trying to get her to relax, use her hearing aids. And eventually we got to a point where she wasn't hearing it anymore, but that was a struggle.
Yeah. And as I often say to the patients, it's quite reasonable for you to be upset about this, whether it's, you know, voices or just the ringing sound. I often tell them, you know, the first, when you hear this, it's not supposed to be there. Your reaction is quite reasonable. And we would all have that reaction. And hopefully you can do other things. And for most, to make this less important for you. And it turns out that most patients, as I tell them this, that most patients are really bothered that first 6 months. And after that first 6 months, for most patients, for some patients it's 2 months, for some patients it's 8 months, they realize that, okay, well, a lot of people have tinnitus, a lot of people are bothered by it at first, but over time they realize that, okay, everybody has challenges in life and it's just a sound, it's not a good sound or bad sound. And for most patients, after 6, 8, 12 months, their reactions to the tinnitus are reduced, and you can be there helping them on that route.
Thank you.
I have a question. I suffer with tinnitus and have as long as I can remember. I don't remember not having ringing in both ears, and it can be quite severe. When I moved to the beach up here, it became about 12 years ago or so. It became much more noticeable after I left the city because of the traffic noise and all of that. Now I hear it constantly, to the point that my ears almost ache. I don't know if that ever happens to anybody else, but it almost can feel sometimes like an earache in both ears. And really high pitched, I notice violins just make me crazy. And I think it has to do with the tinnitus. Have you heard something similar to that?
Yes, there are certainly some patients who say particular sounds trigger the tinnitus and make it worse. Again, it doesn't happen very often, but it does happen. And certainly if you're, you know, if you've been in your previous location where you lived, if you had some background sound and it was there in the background and wasn't so bothersome because the background sound, and then you moved and you don't have that background sound anymore, that's a good indication that you can benefit from sound therapy. And it could be wearable devices, or it could be some sound that you're putting in your room all the time, or putting in your bedroom, wherever your problems are. But wearable devices help a lot of patients. So that's a good example for yourself. Most patients don't experience the pain, but every now and again I do. And again, it's really important to make the distinction between the tinnitus and hyperacusis. Many patients with tinnitus also have hyperacusis, where loud sounds are not just loud, but they can actually be painful sometimes. And these patients are more challenging than the tinnitus patients, but there are some things we usually treat the hyperacusis before the tinnitus, and a lot of the sound therapy approaches help these tinnitus, help the hyperacusis patients as well.